Good evening. My name is Callista Ross, and I'm the Director of Development at the Clinton Presidential Center. Thank you for joining us this evening for our second conversation on health equity. Tonight, our focus is on addressing maternal health disparities. We're so fortunate to have three experts in the field join us this evening. Dr. Carla Ortik will act as our moderator tonight. She's currently on staff at the Women's Specialist of Houston at Texas Children's Pavilion for Women. She served on multiple boards and is a fellow of the American Board of Obstetrics and Gynecology. In addition to providing care to patients, Dr. Ortik is active in organized medicine and advocacy, with past service as Speaker of the House of Delegates and trustee for the National Medical Association. She currently serves as Vice Chair of the Texas State Maternal Morbidity and Mortality Review Committee and Chair of the State Subcommittee on Disparity and Bias in Maternal Health. Our panelists are Dr. Nirvana Manning and Dr. Yolanda Lawson. Dr. Manning graduated the University of Arkansas for Medical Sciences and now serves as chair and assistant professor in the UAMS Department of Obstetrics and Gynecology. She's also the director for Women and Infants Health at the UAMS Women's Health Service Line. In addition to her practice, Dr. Manning is active in many professional organizations, including being a surgical scholar of the Association of Professors of Gynecology and Obstetrics and started the Women's Health Multidisciplinary Elective. Dr. Lawson earned her medical degree from UAMS and is a board-certified OBGYN and founder of Madewell OBGYN in Dallas, Texas. Dr. Lawson is a member of several medical associations and is the immediate past chair of the Board of Trustees of the National Medical Association and serves as medical director of the Turnaround Agenda and Abounding Prosperity. President Bill Clinton has a long-standing commitment to health equity. During his administration, President Clinton, along with HHS Secretary Donna Shalala and Surgeon General Dr. David Satcher, brought much-needed attention to racial and ethnic disparities in healthcare. President Clinton also established the Family and Medical Leave Act, or FMLA, in 1993. One of the first pieces of legislation he signed, FMLA was a breakthrough for women's rights and maternal health. President Clinton has maintained his focus on improving public health and health equity through the Clinton Foundation's work, including the Clinton Health Access Initiative and the Clinton Health Matters Initiative. We're so grateful to our presenting partner, Bank of America, without whom the series would not be possible, as well as our sponsors, the Derek Lewis Foundation, the National Medical Association, and the Arkansas Medical, Dental, and Pharmaceutical Association. Let's get the conversation started.
Hi, thank you, Callista, for that introduction to our evening, and thank you to all attendees. Let's jump right into this conversation. In the U.S., approximately 700 people die from pregnancy-related complications every year, and that's just the tip of the iceberg. Another 50 to 100,000 suffer near-miss severe morbidity events. The death of a mother is a tragic event that has long-term impact on families, physicians, hospital staff, and communities, both economic and emotional, psychological impact. The tragedy is magnified by the fact that approximately 60% of these deaths are preventable. In spite of tremendous media coverage due to high-profile maternal deaths, such as CDC epidemiologist Lieutenant Commander dual doctorate holding Shalon Irving, who died 3 weeks after her delivery from complications of high blood pressure, in spite of feeling unwell and having sought care from her doctor, as well as near-miss episode with Serena Williams having a blood clot in her lung, there remains a lack of awareness regarding maternal deaths. Many believe that the problem is confined to during pregnancy, while the CDC has reported that about 31% of these deaths occur during pregnancy and delivery, but greater than 60% occur after delivery and out to a year following delivery. Likewise, while there's increasing awareness of conditions like hemorrhage or bleeding, high blood pressure, blood clots, and heart disease being among the leading causes of maternal death, there's less awareness of the impact of mental health disorders, including substance use disorder and depression, with suicide being among the leading causes of maternal death in many regions. Maternal mortality rates traditionally are used as an indicator of the quality of healthcare delivery and the health status of a nation. And while a resource-rich nation such as the U.S. would be expected to have a lower maternal mortality rate than other countries, that is not the case. While the U.S. maternal mortality rate has stabilized over recent years, we are the only developed nation to have experienced a rise in maternal mortality from 1990 to 2013. With the first data released since 2007, January of last year, the National Center for Health Statistics released the 2018 U.S. mortality rate at 17.4 deaths per 100,000 live births. For comparison, most recent data reveals that other developed nations report maternal mortality rates of 8 per 100,000 or less, leaving the US with more than twice the rate of maternal mortality than other developed nations. And the impact on people of color, marginalized communities cannot be ignored. American Indian, Alaska Native, Indigenous birthing people experience 2 to 3 times the risk of death as whites. Black birthing people consistently experience 3 to 4 times greater risk of pregnancy-related death than whites. And emerging data reveals that Blacks are also more likely to die from preventable causes than whites. The Black-white maternal mortality inequity is the largest among all conventional perinatal health inequities. This inequity persists even when controlling for multiple variables, including age, how many pregnancies one has had, socioeconomic status, level of education, or the presence of other illnesses like obesity, high blood pressure, and diabetes. It's not surprising that our maternal mortality rate is so high, to me anyway, nor that the racial and socioeconomic inequities and outcomes persist, as maternal mortality truly represents the intersection of racial, ethnic, gender, and economic biases that were at the foundation of our country and still persist. With that brief overview of the issue, let's get into a deeper discussion with our esteemed panelists. To start, I would like to ask each of you, we'll start with Dr. Lawson, if you can share information on the work that you're currently involved in as it relates to maternal health outcomes.
Thank you. Thank you so much, Dr. Ortik. And I want to thank the Clinton Foundation for hosting us tonight. So I just want to state that my overarching, the thing that overarchingly compels me to do the work is my passion to eliminate healthcare disparities, right? And so through that, for me, preventable morbidity and mortality or death are very important aspects to that piece. So I work at the local, state, and national level with organizations such as the National Medical Association. I work locally here in Dallas County also on this topic. And one of the things that I realize is that I'm part of a system, and we understand much of the lack of trust within the system. And I'm talking about the healthcare system. And so I know that I'm a representative within that system. And so I aspire to build trust within that system and restore the community's trust in the healthcare system.
Dr. Manning.
Yes, thank you. Thank you, Dr. Ortik. And again, thank you, the Clinton Foundation, for allowing us the platform with which to talk about this very important issue. And I think anyone that's aware, that's been listening to the news, and as you kind of very well stated, these statistics are very alarming. In the state of Arkansas, I sit on a newly appointed maternal mortality review committee. We were one of the last in the nation to get a review committee, and I'll talk a little bit more about the importance of that hopefully a little bit later. But I think that's a great statewide platform with which we can really get good data. Within our institution and with the surrounding regional programs, we have a maternal quality and perinatal review committee, and so that allows us kind of an ability to kind of talk to other regional programs and really see what what's the difference between what's going on here and what's going on in some of our rural counties. And then within our own hospital, we also have a quality improvement committee that we can robustly just start to do some changes. And once we get a better idea of how to do these, I think it's so much easier for us to kind of spread this out.
I really appreciate those comments. First, Dr. Lawson mentioning building trust. That's an area that, as physicians, all three of us bear some responsibility for, recognizing that there's a lack of trust. Trust has been broken and that we have to work to build it. And Dr. Manning, the comments around reviewing the deaths, understanding, being a part of a review committee, understanding what are some of the key drivers is a critical piece of this, because if we don't know what's causing the deaths, we really can't fix them. So can you elaborate on some of the other key drivers that result in the high U.S. maternal mortality rate and the significant socioeconomic and racial inequities?
I can start if you'd like.
Yeah, go ahead, Dr. Manning.
Certainly. So I think one of the main drivers as to the why, and I think that's where we come to. Why is this going on? How is this happening in such a developed nation? I think that the data has been very cloudy up until now. We haven't had very transparent data. We haven't, terminology has been different, and so it's just been recently in 2003, it was added to birth certificates whether to death certificates, whether the patient had been pregnant within the last 364 days. It was only adopted by all of the states in 2016. So our data is very skewed. With regards to that, many of our hospitals are just not equipped for maternal emergencies. I mean, in the state of Arkansas, we have a lot of rural counties, some hospitals that deliver less than 500 deliveries a year. They may see a maternal death once every 2 to 3 years. And so those numbers have to get aggregated for us to be able to have true data with which we can make real change. I think we have to use the same terminology when we are comparing these things. And I think that's where these maternal mortality review committees in these states are really important. They allow us to systematically look through these deaths and see if there was truly things that we could have done different, and how can we implement policies to make those things different.
Those are some great points. Go ahead, Dr. Lawson.
No, very, very great points. I'd just like to add, when you talk about the disparities in prenatal care, we know that access, right? Your zip code can matter. And then we start looking at these social determinants of health, whether it be transportation, childcare is important. Many times patients may miss appointments. They don't have anyone to keep their kids. Things such as that. So there are these things that are very local, right, and very social that drive some of this. Also, again, rapport and building communication with your providers. One of the things, anytime I'm speaking to patients and groups, is ensuring that patients find a provider that they trust and that they'll listen to, and they should seek those providers for care. Many times patients will migrate, right, to not necessarily the best resources for their care. And then that leads to late diagnosis, worsening of disease states. If it's a thing such as preterm labor, hey, we can't intervene, right, to stop that process. So there are many factors that contribute to that. And I know all of us are in the trenches, right, seeing these patients day for day, understanding these larger structural issues, as Dr. Manning just described, and then those more, right, social issues that our patients deal with. And I think that, again, it's important, and I thank the Clinton Foundation again for promoting this, right, and amplifying these messages to the public.
Yeah.
That's very well said. pick up on that piece about the right resources at the right hospital, the right patient at the right hospital, understanding that high-risk patients need to be prioritized to facilities that have the capability of taking care of the emergency or the high-risk condition that they may have, and beginning to help not only patients and families understand that, but helping providers to understand that as well. Dr. Lawson, you mentioned access, and I want to kind of hone in on that a little bit. Prenatal and delivery care in our country is funded by Medicaid in greater than 40, almost 50% of births. And recent studies have identified that maternal mortality rates are actually lower in states that have expanded Medicaid access under the Affordable Care Act when compared to non-expansion states. Can you talk a bit about how access to healthcare impacts maternal health outcomes?
Absolutely. So we know, and I think back, I remember practicing prior to passage of the Affordable Care Act, and it was a weekly occurrence in my office that pregnancy was a pre-existing condition and a woman would not have coverage. So I applauded when the Affordable Care Act, and now we don't have to deal with that aspect. But again, we continue to deal with this aspect of not expanding Medicaid. And especially when you talk about for patients that are pregnant and those postpartums. I remember being a resident, we had to make sure we got the patient in within that month before their Medicaid expired, get their postpartum checks done, ensure they had birth control. If they missed the appointment, then the patient was without, right? If they couldn't get there and they missed that appointment. But I'd like to say, even when you deal with postpartum follow-up, it's critical, right? So about 40% of women don't have a postpartum visit. And then when you take into account those on Medicaid or without access, right, those numbers are even lower. And again, it's a missed opportunity to manage disparities in maternal and infant health, right? Because there are things that we could target, whether it be depression. We've talked about suicide prevention, preeclampsia. Many people think, oh, I've had my baby, all is good and well and fine. But we know, all of us know, that those symptoms of preeclampsia, eclampsia can still occur up and during until that 6 weeks elapses postpartum. So again, access and tied to payment and those policies around that are very important. And again, I think all of us advocating together for this particular cause to expand Medicaid expansion, just again, when you talk about neonatal and maternal health is very important.
Thanks. I really appreciate that answer. You touched on something that's really important to understand that you don't live your life pregnant, right? And
Right.
so in our country, it's easier to get healthcare coverage while you're pregnant. And so we can take care of you and do the best for you, and you can have every treatment under the sun while you're pregnant. But then once you're not pregnant anymore, you're sort of like the candy wrapper that got thrown away. We take care of our children, but we don't take care of women. We are not making sure that they have safe birth spacing. So you mentioned contraceptive access. You mentioned chronic illness. You know, if you manage a chronic illness before a pregnancy occurs, you're much more likely to have a great pregnancy outcome or a better pregnancy outcome, preventative medicine, that sort of thing. Dr. Manning, do you want to weigh in on that access question?
No, I feel equally strong about that, Dr. Lawson. What we know is in the United States, half of all pregnancies are unplanned.
Mm-hmm.
And so these patients are not coming in with their best foot forward. They have not done the preventative health care measures that we know could put them at worse risk during their pregnancies. I think strongly, I think there's, some states that have definitely expanded Medicaid expansion, which I think is wonderful. But for most states, it ends at 6 weeks to 60 days. And so we do not have an opportunity to follow up on these patients at all and really ensure that we are taking care of them the best way that we can? Are they wanting to get pregnant again within the next year? Let me talk to you about all the forms of contraception that we can do. Let me make sure your mental health issues are well covered. Let me make sure that, if you had a C-section, that these opioids are out of your system, and I haven't now created another problem with this. I think so much of what we can do is in that year or farther, and it's a huge missed opportunity. And I do think access is huge. All of our mothers are coming from different walks of life, and not taking into account where that patient is coming from. I remember, again, as a resident, we'd get so annoyed when someone would be 15 minutes late to an appointment. And now, on the other side, with 3 kids and a busy practice, I couldn't believe they even made it to these appointments, and they have tons of other things going on than I did. Transportation issues. I mean, COVID has brought out a ton of poverty issues and stability of jobs. I mean, there's so many things that are going into this that if we don't start to address those social determinants of health, we're going to get further behind the 8 ball.
Thank you. So Dr. Manning, you just mentioned COVID. We've seen as with many health outcomes, people of color, Blacks, Indigenous, and Hispanics in our country have been disproportionately negatively impacted by the COVID-19 pandemic. Has this impacted your work, and how do you see this impacting maternal health outcomes?
So absolutely. I think COVID has brought out some of the worst in some of these aspects, but also some areas of light. And to kind of tap on that, certainly the disparities have become even more apparent. I think with the mistrust of a lot of medical providers, what's going on there, I think it's brought a lot of this stuff to light, which is wonderful. This is a conversation that we need to be having. We need to be having it on the state level, on the national level. We need to really get down into why is this going on? What is this mistrust? And how can we start to work to better the lives of our patients? And I don't think until we break it down, we'll see the true aspect of that. But certainly access to care, certainly jobs and job insecurities have played a large role in this. I'll tell you what I've seen as a bright light is the expansion of some of the more innovative ideas. Our telemedicine, we've always been fairly good in telemedicine. In March of 2020, we turned that knob, and all of a sudden we expanded our world into telemedicine, and we were able to touch patients and families all over and at least be able to touch base with them. I think, as we talk about access in the postpartum period, touching base with a patient and just seeing if they're okay can really go a long way. And so I think we have seen that this platform really works. We just have to get it to all the patients that we can in all these small communities, such that we can really decrease that gap, I think.
Dr. Lawson?
Yeah, is it okay? Thank you.
Yeah.
No, I thank you for the question. I think Dr. Manning is absolutely correct. We have seen the manifestation of many things with COVID, right? Issues that we may have never realized our patients were having, right? In their households, with work. But for me personally, I spend a lot more time from the mental health aspect. And so there have been times that there'll be patients, you're right, I thought maybe there's some underlying anxiety or depression. So I screen a lot more. I'm having to, but the manifestation of the psychological and emotional issues and depression and anxiety that have been elicited from my clients, really partnering with the mental health community here from that aspect, because there are so many times my patients, if their mental health, right, is not appropriately taken care of, there is a physical manifestation, whether that they stop their medications, they're not taking their insulin, right, their blood pressures are worse, weight gain, obesity, which aggravates other things. So for me, it's really been refocusing myself to support and provide that supportive aspect in the clinical visit with patients, but also with families. And especially with COVID and pregnant women and all of the misinformation we've heard about vaccines, but I've also used it as an opportunity to teach and educate families about vaccines. And even if the woman isn't comfortable, what about that spouse or those grandparents, right, being vaccinated that are going to be directly around this pregnant woman? So I think for me, I've tried to ensure that I provide use it as an opportunity for education in many different aspects.
Thank you for that. You've touched on some things. I do a couple of things. The idea that COVID may create some changes in what we see as leading causes of maternal death. The idea that many patients didn't come to appointments, or, as we learned how to incorporate virtual medicine, we made decisions about who we would see and who we didn't, and we may see some fallout from that. You also talked about the importance of talking to families. You both mentioned the idea that educating families, educating women around some of the signs and symptoms that are critical to recognize is an important part of helping to address maternal health outcomes that piece back to trust again. I'll just mention quickly the CDC is launching a Hear Her campaign, and it's an example of making sure that we listen to our patients and that they learn how to advocate for themselves. And so I want to shift gears a little bit, and we want to start talking about some of the programs that you all are aware of, that you're working on, that are meant to help address the problems, because we do spend a lot of time talking about what the problem is, and I notice in many of these conversations the piece on solutions ends up being a little bit shortchanged, because we're so it is important. We were trying to educate the community on the importance of this, but we need to start looking at what are some of those innovations. So can you talk a little bit about what everyday people can do to advocate for change, and what kinds of policy and budgetary priorities we should be investing in to support improving maternal health in our country? I think we'll start with Dr. Lawson.
Oh, sure. Okay. I think I got the question. So as you heard earlier, I'm the Region 5 trustee for the National Medical Association. So with the National Medical Association, there are 26 sections in all specialties. And so I'll work closely with the OBGYN section. A couple years, we held a maternal mortality summit at our annual meeting, and we published a paper from the findings of that summit in this past fall. And there was some useful information there. And so one of the things that yielded was a collaborative effort, right? Working with emergency room physicians, women's health specialists, midwives, other folks. And so I think one of the things that's important here is inclusive education, right? These aspects are here, all of us are talking, you heard Dr. Manning, and I'm from Arkansas, so I get it, right? Lots of rural communities, outreach, who's doing that? Community health workers, doulas, partnering with these other groups, right? Who can also provide educational resources, because we know the resource of a doctor can be limited, right? Also from the organizational aspect, I know this fall we're planning a town hall on maternal mortality. So we'll be sending out more information on that. And so much of the work that I do, like I said, is through organized medicine outside of the things that I do in my local community to raise the banner for maternal mortality in teaching and education.
Dr. Manning?
No, I love all of that, Dr. Lawson. I'll say, I think another important aspect of the process with which to get to the other side of this is empowering women, is empowering the patients as well. I think the more our patients know about disease processes, about pregnancy, about maternal early warning signs, then they can be their own advocates. And, that takes time, that takes effort, that takes community involvement. It can come from many different ways. It can come from your provider. It can come, just like Dr. Lawson said, from doulas in the community. But I think women really need to be empowered with speaking up when they feel like something is not right and getting that appropriate care. I think another thing in a state like Arkansas is that regionalization of maternal care. We are at the tertiary care hospital at UAMS, and we know that we can't be all things for all people, but we would like to be the things for the patients that really need us, the really sick, the really small, the significant comorbidities, and we know we can do that well. Whereas smaller areas could take care of some of the other complications, preterm labor, mild preeclampsia. And so getting those moms into the appropriate care at the appropriate hospital, I think, is key. And when things get out of hand, to have a structured toolkit with which everyone is standardized and it is just rote memory. It's not variable. Everyone knows what to do with XYZ. If there's a postpartum hemorrhage, this is what you do. You're not thinking outside of the box. It has been given to you. You have done this with simulations. You have talked about it in conferences. And so we really just need a lot more of that education to some of our smaller communities, because like I had mentioned, they may not see maternal deaths very often. They may not see these complications of pregnancy. So when it does come about, it should be very easy to follow. And there's tons of toolkits. The California Quality Collaborative, AIM, they have developed these. We don't have to reinvent the wheel. They are evidence-based, they're standardized, they're efficient, and really getting that engraved and dispersed throughout our states, I think could really go a long way as well.
And Dr. Ortik and Dr. Manning, I'm sure one of you or someone on this call remembers it takes a village, right?
Right. Absolutely.
And so when we're talking about all of this, for me, all I can think of, it takes a village.
It takes a village.
Right.
And I mean, you mentioned, Dr. Manning, the Alliance for Innovation on Maternal Health, or AIM, Maternal Safety and Quality Improvement Initiative, which is an excellent source for data that supports implementation of evidence-based patient safety bundles. Quick for people who are writing things down, www.safehealthcareforeverywoman.org. It's really easy to remember. Safehealthcareforeverywoman.org takes you right to those AIM bundles. And I can toot the horn of Texas that we are an AIM state, and have rolled out the hemorrhage and bundle. We're rolling out the hypertension bundle as we speak. We're a part of the substance use disorder bundle. And what's interesting is each of these bundles does include health equity and speaking to that. You talk about collaboration. I think that it's incredible that CDC is now partnering with the Black Mamas Matter Alliance to begin to engage communities. Dr. Lawson, you mentioned it keeps coming back to that trust piece, making sure that we are centering the voices of the historically marginalized communities in an effort to see improvement. And Dr. Manning, you mentioned including all specialties, large hospital, small hospital. We need our ER providers to understand that someone who has just been pregnant is different than a woman who comes in with mild or moderate high blood pressure. So those are all such critical points. I do want to ask you, before we get to our last question, I want to ask you what you guys think about, or how you see the political landscape. What should we be doing from that perspective to help improve maternal health? And you can't say healthcare for everyone, insurance for everyone, because that's my line. I always say, we have the right to bear arms and to speak freely, but we don't have the right to education or healthcare. So give me something else.
I think we touched on it a little bit, but the expansion of Medicaid, more than 50% of our pregnant mothers are on Medicaid, and the expansion of that to a year postpartum could make amazing strides in the health care of these women. I think we touched on it. We have to be into preventative care and not reactive care. We have to get to the point that we are allowing women to make reproductive choices. If they want contraception, just because they missed that appointment, they have to have the opportunity to do that. And I think policymakers, if I had to have my pick, putting their funds towards that maternal education piece, developing communities that will support these mothers after pregnancy, before pregnancy, and during pregnancy. I think we really do a great job during pregnancy. It's the before and after that we really, I think, miss the ball on.
Dr. Lawson?
Sure, thank you. As I sit and think about it, again, yes, my wish was everyone had access to healthcare and their care was provided for them that they needed. But I think that collectively, all of us, whether it's the March of Dimes, the NMA, ACOG, all of the organizations, I think need to collectively look at collectively advocating on behalf of women. I mean, if you think about the advocacy for women, right, and how effective when we put our minds to it, how we can really get it done. But I think if we really begin to think about the collective nature of advocacy for even just this simple, as you mentioned, to expand Medicaid for 1 year. And what that means, the economic, right, the return on investments there, we know that, right? We know that. Lives saved, we know that. Babies saved, we know that, right? And so I hope, and my prayer and my wish is that we all continue to do this work. Again, meeting you, Dr. Manning. I know Dr. Ortik, the work that she does here in Texas. She's done some things even here in North Texas. And so I think that we really have to figure out strategy and make sure that we continue to be vocal, that we continue to promote and amplify these messages. And as you say, into other communities, right? There are people who I don't even think understood the tip of the iceberg of this until maybe about 3 or 4 years ago, right? There started to be more press about it. There was more on social media about it. People are becoming aware, but there are still folks who aren't, right? There are still folks who walk in my office and say, oh my God, women are dying. But I also want to make sure that we're curating the messages. I'm concerned with the number of young Black women that are afraid to be pregnant now. Right. So I think that it is important that we continue advocacy, education, partnering, like I said, the Clinton Foundation. This is an audience that I hope some of them may or may not know, but different audiences in carrying this work with us wherever we go.
Thank you, Dr. Lawson, for mentioning that, because it does feel like everyone knows the message, right? Because every time that you're on a panel, I'm sure this is true for you, Dr. Manning, being on the review committee, this is, we breathe it, we talk about it all the time, and it feels like, oh my goodness, everyone already knows this, why are we still talking? But the reality is the general public really doesn't have a good understanding of this. And as Dr. Lawson mentioned, boy, oh boy, a lot of Black women are very, very, very frightened. And so we do want to make sure that while we emphasize the importance is that deaths are preventable. That's why it's a tragedy. That's why it's unacceptable. It's not that it's a huge number. It's not that any individual woman is at high risk. It's that the deaths are preventable, and it's that there's inequity in the numbers based on race and socioeconomic status. So I want to give you guys a chance to give a closing statement and take your shot, take your moonshot. What would it take to create a better, safer, more reliable, and equitable maternal health care system? Dr. Manning, we'll start with you.
Okay. Ooh, that is lofty. I like it. A better, safer maternal health care system. I think Dr. Lawson really hit on it in the collaboration. We have to join forces as states, as women. I think, starting from the top, when there's policies being placed, I think women should be at the table. I think they offer a very unique perspective. I think they have real life situations they can bring in there. And I think with any policy changes that women should be sitting at the table. I also think that we really need to address some of the implicit bias and racism that's within the healthcare system. I think until we start breaking down those barriers, we're still just touching on the tip of the iceberg of this. And I think as providers, as doctors, as anyone in the healthcare field, we got into this to help patients. That's what we want to do. And I think sometimes it's very eye-opening seeing kind of the stereotypes or the biases that you may be bringing to the table that you may not even know that you're bringing. And so I think as we think about women in all walks of life, we really have to do more to break down some of those biases. Absolutely healthcare for all. I would love that. But healthcare where it needs to be, healthcare to the communities. If they can stay in the community that they're in, that's the best for that family and that mom and that baby. They have the support system with which to do it. But if they don't and they need a higher level care, we need to make that process seamless for them. And I really think, as we talk about these toolkits and standardizing the care, we hopefully soon will be an AIM state as well. I think getting insurances to fund and back that up. If drawing a line at some point and saying that hospitals need to be a part of these collaboratives, need to be following these best practice and evidence-based mechanisms, I think will put bite behind it as well.
Thank you, Dr. Manning. Dr. Lawson?
So I wrote down 5 words, okay? Again, collaboration, I beat that to death. Communication, right? So communication between teams, providers, and with patients. Education, again, continually educating with the right information. Training, right? Expanding on training. All of us are in institutions where we have residents and students, but also from the community side. And lastly, I wrote diversifying the healthcare workforce. I think it's a relevant issue. It's important because we want to ensure that folks have access to also culturally sensitive and acceptable healthcare, but also this quality. And lastly, I just want to make a comment. So one of the things when I'm talking about collaboration, communication, and training, and I'm not certain if you guys can share this or you've had this experience, but I find that many women also choose out of hospital births, right? And I just really wanted to mention this because many times they choose to birth outside of a hospital, whether it be a birth center at home, because they think they're escaping, right? C-sections, or they're escaping inequities. And again, so I'm always very careful with the messaging because I think depending on how the message is received, right? A person thinks, oh, if I just don't go to the hospital, everything will be okay. But it's much more complex than that. And so I'm, again, happy that we were able to do this tonight. share and educate folks, give them resources where to get great information, but also ensuring that, again, we're collectively collaborating with others who can spread, right, proper information that's correct and accurate, and also sensitive to the needs of our communities.
Wow, powerful words. I do feel like this should have a part 2 because as we are coming to the end, we are just scratching the surface on that issue that Dr. Manning mentioned about bias and racism, and that Dr. Lawson is mentioning about messaging and the importance of not frightening our patients, the women, the people who are birthing. Communication and collaboration, so very important. By raising community awareness regarding the magnitude of the problem, the significant racial inequity, demanding standardization that has come up, standardization of care through implementation of those evidence-based practices at hospitals and all centers that provide maternity care, not just hospitals. Increasing access to quality health care to prevent and manage chronic illness before a person is pregnant. Promoting safe birth spacing via access to safe, effective contraception methods, and implementing programs that increase self-awareness and advocacy. If we do these things, together, we can prevent women from literally dying to give birth. In 2006, then FIGO president, Dr. Mahmoud Fathallah said, women are dying. They're not dying because the disease can't be prevented, but because societies have not decided that their lives are worth saving. I'd like to thank the Clinton Foundation for deciding that lives are worth saving. I'd like to thank Dr. Lawson and Dr. Manning for sharing their expertise, because it's with that expertise that we can save lives. We'd like to thank the National Medical Association, Region 5, and the Derek Lewis Foundation, along with the Arkansas Medical, Dental, and Pharmaceutical Association and Bank of America for sponsoring and convening this panel. And most importantly, I really like to thank our audience for their time and attention on this Zoom platform. We're really sad that we couldn't see you. I know the panelists would have loved to have been able to interact, but we hope that you've enjoyed this. We hope that you've been enlightened by it. And more importantly, we hope you're motivated to advocate for change. Thank you very much.